Well, thank you very much for the invitation. I'm not so sure about the answers. I will talk a lot about histopathology today, where we gain new insight through pancreata that we obtain through the National Pancreatic Organ Donor Consortium that was founded in the US 5 years ago. And in terms of answers, there's more questions than answers when you look at the pathology of type 1 as well as type 2 diabetes, or at least in relation to obesity. As a disclaimer, I will not talk about any Novo Nordisk drugs during their talk, and the histopathology work I present that is done in La Jolla is completely independent from Novo Nordisk. When one looks at the pathology of type 1 diabetes, there are some surprises indeed. And this insight is becoming more clear and more dense now that we have over hundreds of these donor pancreata that we obtain from this ENPOT consortium that is led by Mark Atkinson and was supported initially by the Juvenile Diabetes Foundation. And there are several things we have to bear in mind that also have, as I think, pretty important therapeutic consequences, or at least consequences of how we can consider therapies for type 1 diabetes. For example, when you look at the pre-diabetic phase, we have now many cases that are even triple antibody positive, many more than shown here. You see, and you have to appreciate that it's difficult to find cases in humans that have actually insulitis. Some of these things have already been brought forth by Peter Inveld and by others. And it doesn't mean that there's no insulitis. It probably means that in many cases this can be a relapsing, remitting syndrome of attacks to beta cells. This we have to consider therapeutically, because especially if we had an immune modulator, we would not want to come in during a phase when there is no inflammation in the pancreatic islets. It is also, and I will show you pictures about this later, fraught by regional differences in the pancreas, that some lobes are affected and some lobes might not be affected, which one can appreciate through the ENPOT consortium. At least we can look at the whole pancreas and get an overview what happens in the whole pancreas. Furthermore, it's important to consider the pathology. The main cells that we find in human islets in terms of frequency are CD8 cells, followed by B cells and monocyte macrophages, very few CD4 cells. Now that doesn't allow us to extrapolate to the role of the cells. It's at this point descriptive, but I will show you also some interesting data about the antigenic specificities and what these CD8 lymphocytes actually see when they're in the pancreas. Furthermore, something that had already been described by Alan Fowlis a long time ago, human islets in type 1 diabetes, very different from type 2 diabetes actually, they become sick, they overexpress MHC class 1. And it's not clear still, although this has been described 20 years ago, it's entirely unclear where this MHC class 1 comes from. And we will dwell on this for a couple more minutes because it's a main hallmark pathological finding of type 1 diabetes in humans. So this, for example, here is the pancreas of a 12-year-old boy who unfortunately died in ketoacidosis, and then the pancreas was acquired through the ENPOT consortium. You can see here all this red staining of this islet is MHC class 1 overexpression. In healthy controls, the whole area would be black. So it's an overexpression induced by factors we don't understand. We also usually see it in islets that still have insulin-producing beta cells, which, by the way, we can commonly find, not in large numbers, but clearly find over long times post-diagnosis. So it's not such that at diagnosis of type 1 diabetes, usually all islets have been destroyed. Many islets with this type of inflammation, with the MHC class 1 being high, and with remaining insulin production, can stay there for many years post-diagnosis. And maybe ultimately, in these non-myeloablated bone marrow transplant trials that were conducted by Valtarelli in Brazil, one can appreciate that some of these beta cells that still remain can even be functional, as evidenced by the establishment of nomoglycemia after this rather hard intervention in the study that Valtarelli conducted down in Brazil, where about 60% of patients achieved at least temporary, not permanent, but temporary nomoglycemia. What also you can see here is that CD8 cells there, and you appreciate, for those of you who have worked in mice that the degree of inflammation in human islets, it's much, much less than we usually see in the animal models. It's much less pronounced. And these CD8 cells are the most frequent cells. So that's what we usually see in the pancreas. This MHC class 1, as I indicated, can persist over long times, mostly in islets that still have insulin-producing beta cells, but in some cases just in islets that only have alpha cells left, up to 8 years post-diagnosis. It's not uncommon to see that. So it's a very long, drawn-out process, maybe in some natures relapsing, remitting prior to diagnosis, and then going on in certain pockets of the pancreas up to many, many years post-diagnosis altogether. When you look at the overall distribution, and we have now started, when we look at the histopathology of diabetes, to move from more case-descriptive studies, because we have so many pancreata available, to more comprehensive studies, because our ultimate goal is to draw conclusions that are more far-reaching than what you could maybe extrapolate from a case report. You can appreciate, when we now look at more islets and overall cases, that the overexpression of MHC class 1 is indeed very specific for the islets of type 1 diabetes, and especially when there's still inflammation in the years post-diagnosis. If you keep on going out further than 5 years, 10 years, it slowly abates. It's sometimes already seen in antibody-positive cases. It's certainly much less pronounced in type 2 diabetes. Interestingly, if you compare the islets with the exocrine pancreas, you can appreciate that there's inflammatory processes, maybe more so in type 2 diabetes than in type 1 diabetes, that also affect the exocrine pancreas. And we come back to that in a minute, because when we look at the pathology in insulitis, we also look very carefully at the exocrine pancreas. And there indeed are some surprises, or maybe some underappreciated pathological features, especially in type 1 diabetes. So we can conclude from that, really in type 1, especially right after diagnosis or around that time, MHC class 1 is a hallmark feature for the pathology. We do not know where it comes from, and we can make many elaborate hypotheses. Unfortunately, questions, not the answers, but maybe more questions. But maybe if we put all our heads together, some of us will have answers on this. It's still possible that some of this MHC class 1 is virally related. And as probably many of you know, enteroviruses have been studied in conjunction with diabetes. And in meta-analysis by Maria Craig and others, there's clear evidence that enterovirus infections seem to be in heightened frequency, especially in pediatric diabetes. But it doesn't mean that they are the cause. It could also be a consequence. It could be that islets that are already affected and sick express more class 1, maybe express more viral receptors, and because of that, we see more viral infection that also affects the islets. So the chicken-egg question in this respect is not solved at this point of time. Maybe only solvable if people like certain groups in Finland will develop vaccines to certain enteroviruses, and we see the effect of these vaccines on the incidence of type 1 diabetes in these populations. There has been much interest understanding the innervation of the pancreas. Very little is known, and at the end of the day, we are still left in the dark. The MHC class 1, when you look at cytokines, is most likely not induced by interferon syndromes, at least based on our data, because we cannot see heightened interference in all of the islets that have MHC class 1 upregulation. What is also curious, and maybe some way of better understanding these pathological processes in humans, these hallmark features of CD8 cells and high class 1, we see this very much in alopecia areata. I only learned this several years ago. It was a bit of a surprise to me. It's in the hair follicles, and maybe these are things that we can learn from other diseases in a more easy fashion than, for example, in trials with type 1 diabetes. Altogether, having high class 1, having CD8 cells that have the potential of being killer cells, we hypothesis is that this is a deleterious combination. Mark Pickman and others have studies, at least in vitro, of human islets, where you can show that islet-specific clones can kill these islets. So it's not an unreasonable hypothesis to assume that this combination is not a good one. I will also show you that we can find some of these CD8 cells in the peripheral blood. We have then, based on this insight, looked further what these CD8 cells that you find in human islets might see. And we developed a tetramer staining where we can see what antigenic proteinic peptide pieces these CD8 cells in situ are recognizing by staining with A2 tetramers. This was a technology developed many years ago in Michael Oldstone's lab, and we then collaborated with Bart Rupp and others, also Francesco Dotta, to develop this for in situ staining. Now you can appreciate that you find about, and here you see autoreactive epitopes of various kinds. You find about 1 in 100, maybe 1 in 200 cells. And these are our autoreactive epitopes. You can argue there are possibly many more autoreactive epitopes. So we find cells with self and islet specificity in human islets. And we think this was one of the first evidences that this can be shown in situ in this organ. What we also find, maybe not so surprisingly, we find a fair amount of enterovirus-specific cells. We haven't looked for herpes virus-specific cells. We haven't looked for flu-specific cells. The picture that is emerging is that there's not one clearly recognizable driver cell that would drive the process. We have various autoreactivities. We have virus reactivities. At the end of the day, we might just have a snapshot of what you would also find in the lymph node or in the blood of a human individual because of previous viral exposure. Also, the frequencies of these cells don't prove, in terms of relative frequencies, their relative level of involvement. We can't say that. Why do I say that? Because in animal models, we have models where we drive destruction of islets artificially just by one antigen. And this is one model, is the LCMV model that I list there. Now, in these cases, you get diabetes in 2 weeks. You have one driven antigen, you make the CD8 cells, 2 weeks, all of these mice are diabetic. The frequency we see in the islets and in the pancreas is 1 in 200, so not very high. And there we know this is the driver cell. So in other words, and Larry Steinman had written an article about it many, many years ago, probably in the 90s, we don't know whether among these different specificities, there's some drivers hiding, and we just have no means to easily identify who that might be. Actually, the only mean to prove this would be to induce antigenic tolerance to one of these drivers. And that by itself, we will discuss it at the end of the talk, is not a particularly easy endeavor. So again, here we have some more insight into the specificities. Also other groups working on the TCR repertoire in these islets of human individuals. But we do not know the relative contribution of these cells because at this point we have not been able to selectively eliminate these reactivities for obvious reasons that you might imagine is not very easy to achieve in human individuals. Now we come to some other histopathological features that are all unpublished and that have come up recently when we studied these endpoint pancreata. It's interesting to see that the exocrine pancreas is affected in type 1 diabetes. It's not only smaller, Mark Atkinson and others have demonstrated this pretty clearly by about 30%. It also has this very slight but clearly distinguishable level of infiltration and inflammation, not only by CD8 cells, CD4 cells, monocytes. It's not the full-blown pancreatitis. There's not usually an elevation of enzymes, so we all know that. But there's this exocrine infiltration that's clearly distinguishable. I'll show you data about that. It's curious to see that. It implies that maybe there's also other factors than just islet-specific factors that contribute to the pathogenesis of type 1 diabetes. What is also interesting, when we look in the blood, we can see that you can find autoreactive CD4 cells in type 2 diabetes, as much as you can find them in type 1 diabetes, while CD8 cells are only specific for type 1 diabetes. This finding of autoreactivity in type 2 diabetes is interesting because it speaks to an emerging intersection of all these diseases and maybe a need to, at some point, for new therapeutic development, to reclassify somehow the development of diabetes. So you could say you have diabetes type 1, where you have immune reactivity with these hallmarks. Then you have additional factors that are going to contribute to inflammation. I'll show you some data to that. Some is obesity, some is insulin resistance, maybe metabolic syndrome. And especially if you come into adults, you're going to have type 2 patients who have autoreactivity, just on the CD4 level. Then you're going to have many patients, at least in the US, who are classified with type 2 as adults, who actually are lean and probably have some type of a late onset type 1 diabetes. The evidence that these late onset type 1 diabetes that are seen or were classified maybe as LADA is histopathologically entirely different from a typical type 1 diabetes in kids is also not so great. So on a per islet basis, actually the pathology might look very similar. We have to at least consider this. So at the end, it might be better to classify the immune reactivity, the degree of inflammation, and then other factors such as obesity, insulin resistance, and so forth, as different entities that can come together and then might necessitate different treatment regimens. But these are a lot of hypotheses, so I'm not suggesting change anything right now. I'm just saying we have to look at the pathology very carefully. I'm going to show you some data on how cytokines like interleukin-1 are elevated in relation to type 1 diabetes and also obesity. We have now pretty good data on that. And then I will show you some lobular affectation of the pancreas. So many new things that we have to appreciate. Again, unfortunately, not all answers, but many new questions, but maybe leading to new treatments and new answers. So here you can appreciate how insulitis and exocrine pancreas affectation are sometimes difficult to discern. So often, people will say, well, here's an islet, and look at this. There's some CD8 T cells in there, so we say this is insulitis. But it's really not so easy. Look at this. There's CD8 cells in the exocrine pancreas, and probably in this case, in this area, many more there than really in the islet. So you can't really conclude from that this is a profound islet inflammation. Pathological feature we don't see so rarely in these human cases, and we have to quantitate these things to really fully appreciate who is in the islets, who is in the exocrine pancreas, and how strong these insulitic syndromes are. Now, we have done this, again, trying to move from these case studies more into general quantification, and here you can appreciate like in many human studies that they are spread, can see that the exocrine infiltration here shown for CD8 cells is higher in type 1, but there's a fair amount of variation. Already higher in antibody-positive individuals and certainly higher also in type 2. Some general underlying inflammation. We do not know at this point very well what the difference is in terms of clinical implications between individual who would be here versus there. We don't know that. That, of course, would be a very important question, but we don't know that. When you look at this overall, and you look at CD8 cells in the islet and in the exocrine pancreas, it's also interesting. What you can appreciate that is in the exocrine pancreas, type 1 diabetes, whether there is still insulin-positive islets present or not, this exocrine infiltration seems to be there in certain individuals any which way. If you look at the infiltration of islets, this seems to be pretty much driven in the very majority of the cases by the still presence of insulin-positive beta cells. So there's a fair amount of rationale to assume that insulin-positive beta cells and the reactivity to insulin is a driver for some of the insulitic infiltration and inflammation we are seeing here. The exocrine infiltration might just be an additional contributing factor to the disease in those cases where we can see it present. Now here about the autoreactivity, I told you I would speak about that a bit. You can appreciate here that when we look at autoreactivity in the blood, in a cohort of established diabetics over 12 months, every month, and we summarize the data, and we look with Peakman and Bart Roop's ELISpot assay for autoreactivity, that some type 1s as well as type 2s have these CD4 autoreactivities. And they make different cytokines, and they're just there. They are relatively indistinguishable at that stage between type 1 and type 2. They might be different in younger individuals directly post-diagnosis, but in established diabetes, you can clearly see that you can also find in type 2 diabetes certain individuals with autoreactive cells. Jerry Palmer has suggested that those individuals that have autoreactive cells with type 2 diabetes might fare worse in terms of preserving their C-peptide and insulin production than those who don't have that. We also see a fair amount of degree of spontaneous reactivity in type 1 and type 2, indicating again that there might be a general underlying inflammation. Interesting, for CD8s, it's different. If we quantitate their numbers and epitope specificities using these Q-dot assays that Bart Rupp initially developed, you can see that this is very specific for type 1. Again, what we have to keep in mind though, even sampling over a whole year here, not everybody has this in the blood. And that means that as one possibility, not to complicate the matter further, we have to consider that primary autoreactivity is maybe not always the cause for type 1 diabetes. At least we should keep our minds open. I'm not saying that this is the case. I'm just saying it's a possibility. And it might be possible, in my mind it's about 50-50, that is an autoimmune-driven primary autoimmune disease. It's entirely possible. Or that there is, that's the other 50%, another cause, and that autoreactivity comes on secondarily and then becomes, albeit it being secondarily, still a clinical problem once it has been established. We don't know that for a fact, so I've gotten very careful when I write my reviews. Initially, I always wrote it's a primary autoimmune disease. Now I write it's an inflammatory disease, and we don't know whether primary autoimmunity is the cause for the disease per se. That's not arguing that autoimmunity is a fundamental problem based on Sutherland's pancreas retransplant studies and so forth. Once it's established, there's relatively little doubt in my mind it's a fundamental problem. But whether it's the primary cause for development of the disease, we don't know for sure. Last but not least, the cytokines. We look at them now very systematically. We look at them on the RNA level, seeing here on the left-hand side in an islet by in situ hybridization, this is for IL-1, and here on the protein level in a confocal microscope. Now, when you have these incidental islets, when you look at these pancreata and at many islets, you will very rapidly appreciate that there's a fundamental amount of heterogeneity in any type of pancreas. Healthy controls, where these hybridizations give positive data, in the exocrine pancreas, in the islets. So there's a very strong need to move this from observational single islet studies to a more systematic overview. We have started to do that. You see more heterogeneity. What you can appreciate is that in obese type 1, this IL-1 is mostly elevated, more than in type 2 in our cohort, and maybe already in antibody positive type of patients. What is also interesting, when you look relatively where IL-1 is it in the exocrine pancreas or is it in the islet? And we do this blinded now with 3 operators in La Jolla to quantitate this. You can say that in general, when it's in lean individuals versus obese type 1 individuals, the obesity pushes inflammation maybe more into the islets than the diabetes itself. So that's one of the things that I find surprising, but maybe can tell us where the origin is of these inflammatory cytokines. And it can probably also tell us something about why trials, in this case blocking IL-1 in type 1 diabetes, have not been entirely successful. Last but not least, and this is my last histopathological point, also coupled with a movie, before we talk a little bit about therapeutic approaches and biomarkers based on this pathological insight. We see often, and this is very puzzling to me, in human diabetes, lobular, not patchy, really lobular affectation of the pancreas. See this? So this is a diabetic individual pancreas, and you can see that only in the upper right-hand corner, I think that's given up on me, only in the upper right-hand corner, you still have an area with high MHC class 1 and islets with insulin production. The rest, obviously, devoid of islets. But you can ask, why just this corner? Why this lobe? Why not just random islets like we see in animal models? Why not patchiness like you would see in alopecia or vitiligo? Very, very strange that this is a lobular type of situation. Now, you could argue maybe there's something that has to do with the supply of the lobes, maybe it has to do with the entry, or maybe it has to do with viral infections. We don't know that. Maybe the most easiest and simplistic explanation, and this is something you can appreciate in this 2-photon movie where we track CD8 cells now in a mouse model, is that once lymphocytes reach into a lobe of the pancreas, what you can see here is that they're roaming, they hold on to certain structures, but they're roaming is entirely free. They can sort of reach around in the exocrine organ pretty freely. And it's also interesting to see that already in a mouse, if we want to extrapolate, they don't come through the islets. They come through the exocrine pancreas and then they search around. When you quantitate their directional behavior, this was published in JCI some years ago from our team, they are not directional when they are in the exocrine pancreas. They are more like ants searching for food on the floor, and then when they see the islets, they slow down. So it's a random search mission, even in the mouse model. And you could argue maybe there's an entry event that destines the whole lobe of the human pancreas for then becoming under attack. And once this lobe comes under attack, the islets in that particular lobe are in danger. And maybe that's why sometimes we don't see insulitis, because the disease progresses lobe by lobe through the human pancreas till we reach a level of insufficient beta cell mass, at least in some cases. Now, when you take all this together, and I want to close on these immunotherapeutic thoughts, because they're obviously complicating the matter of treatment for type 1 diabetes. So you can, of course, ask, why has this been so difficult to treat type 1 diabetes? For me, this really comes down again and again to the dilemma of side effects and benefits, and how we all can disagree on where the sweet spot is for a given patient and what you really can take in terms of immunosuppression, especially in the face of ever-improving pumps and sensors and so forth. This becomes, of course, a matter of, rightfully so, quite some scrutiny. And you can say the immune system is important for the disease. This we know from these bone marrow transplant trials. You can revert the disease, but the side effects are too high. And there are some other drugs that maybe have high side effects. So how are we going to balance this out? Is there even a role for immunotherapy in type 1 diabetes, where the bar is ever becoming higher and the bar of what patients are willing to tolerate? It's not an easy question. And you can say that with some recent trials like the anti-CD3s, you have seen the dilemma. The endpoints were set very aggressively, but then these drugs don't reach the endpoint. But the endpoints were set aggressively because people wanted to provide a sufficient benefit for the patient with these drugs to justify giving them. So maybe the answer lies in two things. One is combination therapies, I would argue for, and I would argue we have to do them from the get-go. We can't just do monotherapies, get the evidence that a monotherapeutic drug works really quite well, and then move forward with combination therapies. The benefit of a single drug therapy might never reach the level that you can justify its use in a large amount of individuals. So maybe coming in with combinations, smartly designed, synergistic, evidenced in animal models, is a better way to go. These are the candidates. They're not different from what Jay Schuyler or other people would put up here. I think we are pretty much in agreement. We need an antigenic tolerance, we need GLP-1s, we need anti-inflammatory therapy, and a good anti-T cell drug. The ones on the right-hand side, which will have more systemic side effects, just as an induction therapy. That's how I look at it. So that's one part. The other part is the part of how you move to a more individualized therapy without making too many subsets in trials that are already difficult to conduct because of C-peptide decline being heterogeneous, maybe because of individual heterogeneity, as we all know. So we think we can do some things in animal models that are pretty well rationalized. We can look at side effects and use this then as a priority scheme. We can look at biomarkers to identify responders, and I'll show you before I end 2 examples of that. And we can look at combinability, and only if we have the most promising drugs there, then we move them forward to proof of concept trials in humans, which actually, to get an idea whether something works, they are not so small trials. Where we stand now, especially there's a push of doing many of these trials now in adults, probably need about between 50 and 80 people per arm, which is not a small trial, especially if you think about a well-conducted combination therapy trial. Now, how could things be individualized without just doing a rather unbiased screening? I'm a big friend on having hypothesis-driven things. I think we can do things with autoantibodies. There's evidence here from animal models that mice who have insulin autoantibodies are easier treatable with antigenic therapy than mice who don't have insulin autoantibodies. And we can use autoreactive CD8 cells, which are anyways the most frequent cell in the islet. At least in mice, we can do a very clear stratification who will respond, who will develop diabetes faster and slower. Now, Bart Rupp has done this in Walter Relly's cohort, and indeed, those who have a high load of autoreactive CD8 cells, even with a non-myeloablative bone marrow transplant, much harder to treat than those who had a lower level. And these, I think, are feasible things. We can make GMP assays that we could have as a companion diagnostic for trials, and we could use them for fractionating those who will respond better into those who won't respond better. I'm going to close on that thought, at least a little start maybe for individualized medicine down the road. Histopathology team, mostly led by Teresa Rodriguez in La Jolla at this point. Several collaborators through the NPOD consortium as shown there. And then biomarker team at Novo Nordisk, from whom I showed you some data of the fractionation for antibodies and CD8 cells, Ken, Jonna, Tamar, and Nicole. Thanks very much.